afternoon and welcome everyone. I, Dr. 𝗔𝗟𝗵𝗵𝗏, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's session. On the occasion of World Alzheimer's Day, Voice of Healthcare has taken an initiative to bring together the experts and speakers for this resourceful discussion today. In this discussion, our speakers will talk about the latest trends and approaches with a focus on post diagnosis support, which are taking place to boost the myths related to Alzheimer's into the community. I would like to commence this session by introducing our eminent speakers. Dr. Sumit Singh. He is the Chief of Department of Neurology at Artemis Hospitals. Welcome, Dr. Singh.
Thank you.
Dr. P.K. Sethi. He is Emeritus Consultant, Advisor and Professor Neurology at Sri Ganga Hospital, New Delhi. Welcome, Dr. Sethi.
Thank you very much.
Dr. Lieutenant General C.S. Narayanan. He is HOD and Consultant, Department of Neurology at Manipal Hospitals, Dwarka. Welcome, Dr. Narayanan.
Thank you.
Dr. Praveen Gupta, he is the Principal Director, Neurology at Fortis Memorial Research Institute, Gurugram. He'll be joining in there in a while. Dr. Nithin Kumar N, he is Consultant Neurology at Fortis Hospital, Bangalore. Welcome, Dr. Kumar.
Thank you.
Along with sharing his views, Dr. Kumar will also be moderating today's session. So without further delay, I would like Dr. Kumar N to lead this session.
Thank you, Dr. Ritika. Thanks for welcoming the esteemed and eminent neurologists of India. And I'm pleased and very delighted to be moderating this panel discussion. So today being the World Alzheimer's Day, we shall be having an elaborate discussion on dementias and with particular reference to Alzheimer's disease, its clinical signs, diagnosis, the management, the care, and much more updates about this particular condition. So this is going to be discussed in elaborate way. So I'm very happy to be a part of this particular discussion. So welcoming you all, sirs, again. So what I'm going to do is I'm going to ask the questions, and our speakers are going to give their opinions, answers, and their enriched knowledge will definitely be helping us in a great way. So I'm going to start the session now. So the first question is to Dr. Sumit Singh. Dr. Sumit Singh, what are the early signs and symptoms of dementia? So for a common man, how to understand that if he's really having the signs and symptoms of dementia? Over to you, sir, Dr. Sumit Singh.
Yeah, thank you. I think that is the single most important question. And what happens is that many of these patients, they come to us with the problems of memory loss. Now, the memory loss is very, very common for minor things. So where you have kept your keys, where did you put your spectacles, you forget the name of a person when you meet him in the party or in a dinner or a lunch. Meeting somebody and then just not remembering where you had met him or her before. This is very, very common, and people often start getting, jittery about having these problems. But this is not amounting to dementia. Dementia is when you start forgetting things which actually matter to you. Many times patients would be coming and they would be saying, hey, doctor, this is a father of mine. He has a very, very good memory and he just remembers what was the venue of his marriage. He also remembers who were the guests and what was the menu and the food. So they think that old memory and retaining of old memory is also a very, very good thing. And they would always vouch that their memory is good. So actually, the dementia part is a primary problem of memory plus other aspects of cognition. So it is usually retention of new knowledge or attainment and remembrance of new knowledge which is lost the most in patients with any type of dementia first. Now, if the memory is lost, then apart from that, there would be other signs which would be evolving. So a patient might forget where he kept his slippers, that is okay. But when he forgets whether he has had his food or not, whether he has had his medicines or not, whether he's becoming confused, whether it is the morning or the evening, He's forgetting how to go to the washroom or going to the kitchen. He goes out to have a stroll in the garden, and then he forgets how to return back to his own house. He starts forgetting near and dear relatives. He starts doing things wrongly, particularly the things which he's been doing on a regular basis. For example, a lady might forget how to cook. A gentleman might forget how to tie his braces, or to tie a knot of his tie. So these things, when they start happening, these are the causes of concern, and then it is important that such patients are considered as having possibility of onset of dementia. You are on mute. Dr. Nithin, you are on mute.
Yes, sir. Yeah, thank you. Thank you very much, sir. That was very elaborate. And let's move on to the next question. So this next question is to Dr. Professor P.K. Sethi. Sir, what is the difference between dementia and Alzheimer's? So this question is basically based on the common knowledge that most of us feel that dementia means Alzheimer's disease. That means it's like a synonymous thing. So we want you to please elaborate, sir. How do we differentiate dementia and Alzheimer's dementia? Please, sir. Dr. P.K.
Yeah,
Sethi.
thank you very much. You are very right. Many times people take it for Alzheimer and dementia. Dr. Singh has very nicely explained what dementia is all about. Dementia, he has just said, cognitive problems, especially the memory, but it may also affect your judgment, your communication skills, and many times there are behavior things added to it. When it becomes so much that you are having difficulty in your social working and time to day-to-day working, then the dementia set in. Alzheimer is one of the dementias. So dementia is a much broader thing. But Alzheimer, 2/3 of dementia cases is given by the Alzheimer disease. So Alzheimer disease is part and parcel of one of the diseases of dementia. The other things are vascular dementia or mixed dementia, where there is a Alzheimer plus vascular. Third, there are other causes of so-called treatable drugs, neoplastic lesions, hydrocephalus, where is the actual structural loss of the things, and B12 deficiency and other. So Alzheimer is one of the 2/3 patients of dementia actually belongs to Alzheimer. So Alzheimer in a way is a bigger way, and you're very right, sometimes they use the interchangeable, but it's not necessarily an interchangeable thing. And therefore, one should be sure when you are seeing Alzheimer's disease.
Thank you, sir. It was a very lucid explanation. So thank you again. So we'll move on to the next question. And this question is to Dr. C.S. Narayanan. Dr. C.S. Narayanan, so diagnosing Alzheimer's, what are the various methods available in India? What are the clinical tools, or even more than that, what do we have in India? And the most important is like how early we can diagnose this particular disease so that we can intervene at the earliest. So please, sir, can you just put some your thoughts on this question?
Yeah,
Dr.
thank you so much, Dr. Nithin. And like Dr. Sumit Singh explained very elegantly the early symptoms of Alzheimer's disease. The diagnosis of Alzheimer's disease rests predominantly on these early symptoms that Dr. Sumit Singh has already said, which starts off with memory impairment and subsequently goes on to involve other domains of cognitive functioning of the brain. So this is the first step and the most important step, and this is the step which can be identified first either by the patient or by the caregivers. In fact, you must interview both the patient and caregivers independently to find out what problems they have in their day-to-day functioning. So they should have both memory issues, involvement of other domains of cognition. It should significantly impact their activities of daily living. That is part of the definition of Alzheimer's disease. and there should be a certain drop from their level of performance in the past. So these are all part of the definitions which have been laid out by various societies for Alzheimer's disease. And this actually is the single most important step for the diagnosis of Alzheimer's. And subsequently, of course, we take recourse to some formal neuropsychological assessment scales. The two most common ones are, one is called a mini mental status scale, which almost all neurologists are very aware of. It takes almost only 5 minutes to administer. It's not very difficult. But there are some deficiencies of this MMSE. So there's a new scale called the Montreal Cognitive Assessment Scale, which tests for some specific aspects like language and executive function, which are equally important for the diagnosis of Alzheimer's. So we can actually administer both the scales. And there are some even more refined scales which are available, but which cannot be administered in the clinic setting. So we must take recourse to referring the patient to a neuropsychologist. After that, we come to certain other tests, which of course are available in India as well. One, of course, is the MRI. The MRI is a relatively non-specific kind of a test. It does not kind of confirm the diagnosis, but it is more important to exclude other conditions which can mimic Alzheimer's disease. So this is a very important step. There are some findings which can support the diagnosis of Alzheimer's. There is generalized atrophy of the brain. There can also be some focal atrophy of certain specific parts of the brain, like the hippocampal lobe, which subserve memory. Then the precuneus, which is the mesial part of the parietal lobe, the lateral parietal lobe, or the posterior temporal lobe. So these are all kind of can suggest but cannot confirm the diagnosis of Alzheimer's. Then we go on to certain other types of imaging modalities which we don't have routinely in India, which are available in the context of research settings, which use amyloid imaging and tauopathies. After that, there are certain biomarkers. Again, this is in the research setting, like the amount of amyloid beta 42 in the CSF, the amount of either plain tau or phosphorylated tau in the CSF. And lastly, what is the value of other laboratory tests? In fact, none of the other laboratory tests contribute to the diagnosis of Alzheimer's, but they can definitely tell us about the confounding factors which can aggravate the memory loss or the cognitive problems that the patient has. And then lastly, moving on to the genetics. So particularly in early onset Alzheimer's disease, where there's a very strong family history, particularly of autosomal dominant Alzheimer's, which only accounts for about 1% of all patients with Alzheimer's disease. We can do some genetic testing of specific genes like the amyloid precursor protein gene, the presenilin-1, presenilin-2. These are markers for autosomally dominant Alzheimer's disease. So a family member who's actually exhibiting the symptoms, we can go on to test. But we must be very, very chary of doing the test, blunderbuss, like some commercial organization like to sell it that, okay, we'll do it for everyone to screen you for Alzheimer's. There are a lot of ethical issues, so we must not take recourse to that. And in the older age group, the apolipoprotein E epsilon 4, which is susceptibility gene, can be tested. And so these are all the tools in our armamentarium to diagnose Alzheimer's. And I would still emphasize that it is predominantly a clinical diagnosis.
Thank you, sir. That was very elaborate. And of course, you stressed the importance of the clinical judgment, which is most important in most of these cases, apart from the, of course, the radiology and the other techniques. So the next question is to Dr. Praveen. Sir, warm welcome, sir. Happy to see you. Sir, the next question is to you. I mean, the question is, what all approaches can be taken for dementia post-diagnosis? So once we make a diagnosis of dementia, then how do we approach this case? What kind of care needs to be given to the patient? And of course, medications, you can elaborate, sir. Dr. Praveen, you can go
So
ahead.
it is a very important question. Dementia is not just a disease of patient, but it's a disease of the family. Apart from prescribing therapeutic medication, which we all know doesn't cure dementia, counseling of patients and setting the context on what to expect. What are the stages where patients may require support? to establish specific caregiver support and to give counseling and training to caregivers is also very important for dementia. There is therapeutic support in terms of medicines which are called cholinesterase inhibitors, three of which are available in our country, which is rivastigmine, galantamine, and donepezil. And there is memantine which can be given. There are some nutraceuticals which people use for some of the dementia patients. Then dementia is associated with significant behavior problems like agitation, hyperactivity, hallucinations, sleep disturbances, which are more discomforting to the family than dementia itself. So these psychiatric comorbidities of dementia require specific intervention, and more than dementia, many medicines are available to make the life of the patient and family comfortable. But we should not stop at prescribing medication because there are many interventions like behavior therapy, socially involving the patient, doing intellectually stimulating active with the patients. Even yoga and meditation has been shown to be of some benefit in dementia patients. Then caregiver counseling on how to deal with dementia patients, because these old people sometimes start using language which offends their families or their wives or their children. How to approach that, how to deal with that, how much to confront the patient in case of memory loss is to be all taught to the caregivers so they understand the needs of dementia patient and follow it. Also involving social organizations so that we can give caregiver support. Some rest to the caregiver is also a very important aspect of dementia treatment. So this holistic broad-based treatment is how we should approach dementia. Thank you.
Thank you very much, sir. Now, moving on to the next question. So, this question is to Dr. Sumit Singh. So, what are the risk factors for dementia and how can the risk be reduced, sir? Of course, the risks could be many, and the most elaborate, most important ones, and of course, the other risks you can explain, sir. Please, Dr. Sumit Singh.
Yeah. So it is that way that there are no proven risk factors which can say that this patient is definitely going to develop dementia and this patient is not. But yes, the risk factors can be divided into two. Some would be the modifiable risk factors, and then there would be the non-modifiable risk factors. So you can't change if you are a male. You can't change if you have achieved a particular age. So male sex and old age are. Then there are certain ethnicities which are supposed to be associated with the higher risk factors. So Caucasians are the ones which have a higher risk of dementia as compared to the region which we belong to. Then apart from that, there would be a genetic predisposition. So if there's a family history of dementia, then patients of Alzheimer's particularly, there's a higher possibility of their siblings or their kids to be affected with dementia. As Dr. C.S. Narayanan just now told us, the apolipoprotein allele, so epsilon apolipoprotein allele, if it is associated with the homozygous condition, that is also a non-modifiable risk factors. Then there would be other risk factors which are the modifiable ones. So while it might not be of much benefit in preventing patients from having a worsening of dementia if they have already developed. But if we do a primordial prevention, then control of lipids, particularly the low density lipoproteins, maintaining adequate vitamin B12 levels, hypothyroid states, repeated head injuries, and diabetes and hypertension. These are the other things which are the disorders which are associated with the higher risk. And then personal choices of smoking, drug addiction, particularly the drugs which are associated with psychoactivity, the repeated head injuries, excessive alcohol consumption. These are the other modifiable personal risk factors which are associated with the increased risk of dementia, particularly Alzheimer's.
Okay, sir. Thank you very much for that elaborate explanation of the risk factors. Now, moving on to the next question, we would like to have Dr. P.K. Sethi. So, sir, the question is regarding the Alzheimer's disease, what are the genetics and associated risk factors? So, we want you to elaborate on the genetics of this disease.
Thank you very much for asking that question. Genetics has come in a big way now in all diseases, especially in Alzheimer. We read so much about genetics now, and it is this. Many times a patient will ask you, suppose has been told by Dr. Sumit Singh and touched by 𝗔𝗟𝗭𝗛𝗚 that having made a diagnosis, the patient relation they come next day to you, his brother or sister, and his real first one. He has got dementia. What is my chance of how my mom has dementia or my father has dementia? What is my chance of getting dementia? Very valid question, very important question, very pertinent. Now genetics is now developing in a bigger way, in a rough way, so that we can comprehend what we are saying. I can make it kind of imagine a circle in which there is 75% patients are sporadic and only 25% are familial. Where if you trace, as has been emphasized by previous speakers, family tree up to 3 pedigree, you may find that there have been patients who had a dementia. So that comes in a separate group, a small group of 25%, which is familial. In that familial group, which I am dealing now, then it has been divided into 2. One is small familial, which is early onset, say about 40, 45, 50. There, less than 5% have a dominant gene, single gene. That is one more single gene. They have been discovered about 10 years ago. So if you have a patient who is a younger and there may be a single gene. So that is very important. And generally they are early onset, say 40 or 50. There may be a in the familial group, this second group, which is constitutes about 20%. 5%, less than 5% is an early onset, 20% is the late onset. These familial groups, large amount of patients may be not, they don't have a gene, genetic one gene, dominant gene. They may have a complex heredity. So there may be more than one gene about which we are still not very sure, some are being discovered. So one small group, less than 5%, which is early onset, and the late onset is a bigger group, which is familial, but they may have a complex heredity, a complex genetics. Now we come to the larger group. At this juncture, I will take a break with your permission to put in right why this Alzheimer has become so important. The earlier days when I was studying in AIMS and we were growing up as neurologists, we used to debate a lot that Alzheimer does not exist in India. The reason very simply was that autopsies are not available, and we believed that unless you do autopsies and you find senile plaques or neurofibrillary tangles, only then you can say that patient has Alzheimer. Then came a big study from Europe. That earlier it was this group, which I referred earlier to you, 5%, was called pre-senile, which was the Alzheimer disease, which was originally described by the Alzheimer psychiatrist in Germany. The big group, then they found what we used to call those days senile dementia. When they came on autopsy, they found that neuropathology was same senile plaques, same neurofibrillary tangles. Then they found that there is no difference. They presented in the same way, that same neuropathology, and suddenly the Alzheimer group really expanded to become 2/3 of all the dementias. So this thing is to be kept in mind. So earlier it was, which was morely a genetic. Now this bigger group, which now is, that is more, as has been emphasized by Sumit Singh and by 𝗔𝗟𝗭𝗛𝗵𝗵𝗺, that the age, as age advances, which Sumit Singh has said, which you cannot be reversed it, as the age advances, after 80, it seems 50% people of us may go into dementia, and that every 4 or 5 years, this group may be increasing. Now, what does about this sporadic big 75% group? They are all adult onset. They present the same way as the earlier group, which is younger group. They have same the neuropathology, but they are the things, they don't have that genetic single gene, the dominant gene. They have morely, as has been referred by earlier speaker, APO, alpha protein, lipoprotein E, which is the one which is now getting a lot of attention, and there too, that is, it is a carrier of gene carrier which contains this apolipoprotein. If that is disordered, then you may get this, but it's not easily available to test in everybody. And even if the test is positive in a given person like me, suppose my relation has this thing, it is not necessary that I will go into dementia, because there are many more factors. That is our genes is polygenetics. So then in this group, which is a bigger group, about older age onset, there is, as been referred earlier, there is genetic plus environmental factor. The environmental factors are gaining much more ground now. Environment, which has been referred to, it is your education, how good you are. It seems the more you are educated, less chances that you have that you will get Alzheimer. Physical activity has come in a big way. It has come, even a guy who walks, say, 3 times in a week or 4 times, actually is doing good for his health. So surprisingly, it came, physical activity is not only good for your physical thing, but also your brain health. Third thing, most important, which has come, the feeling of self-importance. कि मैं भी कुछ हूँ. If I am so and so, Narayanan is Narayanan, Sumit Singh is Sumit Singh. And if they feel, and as you feel, that you are a neurologist, that you are chosen one, so that feeling, if it remains in your head, you don't go down so quickly. That itself, the feeling of self-importance, also prevents, is an environmental factor. In the USA, this lady came in a big way, where they make these mobile cars. There they found a lot of heavy metals, aluminum. They are really adding toxic metals. Very nice of Sumit Singh and Jan Saab to mention. In USA, when you are working initially, first, if you have a dementia, first you ask for a minimum investigation is MRI and thyroid. And second, beta, because that way you may be able to zoom down to reversible. Now, which has been added is autoimmune encephalitis has come in a big way, which is coming as autoimmune encephalitis dementia. There are treatable dementias today. At this juncture, I'll take a break. I think Sumit knows we have discussed this thing long ago. Dementia versus depression. There's one good test. If the patient, very rough test, if patient comes and tells you, look, मेरी memory जा रही है, मुझे ये ठीक नहीं लग रहा, मैं भूल जाता हूँ, probably he has depression. But if the patient's relation bring to him, that इसकी memory आ रही है, और वो कहता नहीं मैं नहीं जा रही, मैं तो ठीक हूँ, then probably he is going into Alzheimer. Same thing which has been described now is given, turning your head, one clinical sign, which I used to say, that if you ask him, तेरे grandchildren कितने हैं, so you will ask his son, तो अपने बच्चों का नाम बताओ ना, इनको डॉक्टर साहब पूछ रहे हैं. So turning his head to the speaker. So turning his head to the speaker and asking, या तो डॉक्टर साहब पूछ रहे तो बता नहीं रहा. He himself is trying to cover. So I think that is very important. And genetics, more and more genetics will be coming. But at this juncture, we don't go there and say, अच्छा तेरे जीन कर लेता हूँ, तुझे पता चल जाएगा, तेरे को Alzheimer है, होगा कि नहीं. I think it's too early for that. Therefore, I end here by telling that environmental factors are very important, especially physical exercise is coming in a big way. how diet is coming in a big way, diabetes is coming in a way, blood pressure. It is all vascular now, not just what we used to say multiple infarction dementia. Now it's come even in Alzheimer, lot of part is being played by vascular elements. Nithin, I'll end there.
Thank you, sir. That was very, very well presented. You had spoken on very intricate topic of genetics, and made it very easy. You spoke about the other risk factors and reversible dementias, and the importance of the self-esteem. A lot of topics you did cover, sir. Thank you so much for that. So we'll move on to the next question. This question is to Dr. C.S. Narayanan. Sir, we want to know the treatment modalities in dementias available as of now, particularly for the Alzheimer's disease, and any other management further, apart from the treatment to anything more you can tell us, sir. Please go ahead, sir. You can unmute your...
Sorry.
Yes,
I think you're
all the
muted.
panelists have discussed, there are two approaches to the treatment of dementia, particularly Alzheimer's disease. One is the non-pharmacological approach, which is very important, and also specifically the question pertains to the pharmacological treatment. So in pharmacological treatment of early dementia, particularly when the person has got only memory loss or in the early stages, when the MMSE score is between 18 to 24, then we have two drugs which raise the level of acetylcholine in the brain, which is the main chemical modulating memory. And the drugs to increase acetylcholine levels are donepezil, rivastigmine, and galantamine. So all the drugs are available with us. All of them are equally efficacious. The side effect profile is different, and they're all also available in various formulations. For example, rivastigmine is available both as a tablet and it is also available as a patch, which increases the bioavailability and reduces the side effects as well. And as we go on to the later stages of dementia, then we have a drug called memantine, which reduces the excitotoxic effects of a neurotransmitter called in the brain. And subsequently, the most interest is generated by some of the newer molecules which are available to us worldwide, but not so far in India. There is a monoclonal antibody called adalimumab. It is actually very important to know because there's a lot of hype that one sees in the lay press about when a new molecule is introduced, and they always come out and say this is the ultimate treatment for dementia and a revolutionary drug and things like that. But if you go through the fine print, there are a lot of caveats for using this new molecule. Firstly, the patient has to be very well selected before they're put on this molecule. They have to be tested, and confirm that they have amyloidopathy by doing amyloid PET scan, which is, I told you, it is not available in India at all. So we must not use it. And about 40% of patients who are exposed to this monoclonal antibody go on to develop something called amyloid-related imaging abnormality, which is not a very substantial number. And these patients have several other clinical problems as well. They have falls, they have confusion, they have diarrhea, they have a lot of other issues. And more specifically, two types of ARIA, as it is called, is there. One is associated edema of the brain, and this resembles what we have always known as something called PRES, or posterior reversible encephalopathy syndrome. So this is the one presentation. The second presentation is even more alarming. Is this ARIA is also associated with hemorrhages in the brain. It could be micro hemorrhages or it could be macro hemorrhages leading to a substantial bleeding in the brain. So these patients also have to be screened for the presence of these micro hemorrhages before they are put onto this therapy as well. So there are a lot of caveats, but I have seen several times in the lay press that some of these new molecules are touted as being revolutionary. So at the end of the day, as far as pharmacological treatment goes, all of us as of now confine ourselves to these anticholinesterase inhibitors like donepezil, rivastigmine, and galantamine in the early stages. Then we add on memantine in the later stages. So, and one question which may be asked, which is very relevant, is what about some of the other drugs like the estrogen replacement, the role of non-steroidal anti-inflammatory drugs like statin, like aspirin. What about statins? What about 𝗔𝗟𝗵𝗺𝗏? What about antioxidants? None of these other modalities of treatment have been found to be effective. There is some data for the benefit of vitamin E. So some authors use vitamin E not because they know that it is extraordinarily beneficial, but because the side effect profile is very acceptable. So we can give these anticholinesterase inhibitors along with vitamin E. Then there is another antioxidant called salicylic, which we use routinely for Parkinson's disease. Again, since the side effect profile is much worse, at least I do not like to use salicylic. And having said all this, going back to what all of us have discussed again, the major aspect of dementia management revolves around the other things which the patient may have. They may have vascular risk factors, which, as Dr. Sumit has already said, predispose the patient to the progression of his cognitive issue. So we must manage those vascular risk factors as well if we want to treat the patient holistically. And thereafter, we have to give advice regarding certain societal and safety issues as well. For example, whether the patient is able to drive or not to drive. So we have to take recourse to some formal neuropsychological test to make sure that the patient is able to. It may not be such a big problem in India, but depriving a person the right to drive abroad is almost giving a death warrant. In India, we have recourse to so many other types of transport, but in foreign countries, it is not so. So that is a very major decision. Whether they are able to handle their own finances is another very major issue. So the advice has to be given at various points of time, very targeted advice to these patients and their caregivers about all these issues.
Yes, sir. Thank you very much, sir. That was very, very lucid explanation of the treatment. So now we'll move on to the next question. This question is to Dr. Praveen Gupta. So we want you to speak on living with dementia, the recommendations for caregivers, and helpful tips to keep in mind. So we know the burden of dementia and such neurodegenerative disorders on the family, the caregivers, burnt
I
out
can't
syndrome.
listen to anything.
Can you listen now, sir? Can you hear me now, sir? Am I audible?
Yes, you're audible.
Yeah, you are audible, Nithin.
I'll once again repeat the question for you, sir, to Dr. Praveen Gupta. So we want your inputs on the recommendations for the caregivers and helpful tips to keep in mind. So that's basically living with dementia. So what are the recommendations to the caregivers?
I have said earlier, is a very important aspect, possibly as important as therapeutics in dementia, because dementia doesn't affect the patient alone, it affects the whole family. So, caregiver counseling, caregiver knowledge, caregiver support is a very, very important aspect of dementia treatment. So, we have to advise caregivers about multiple things which include how to deal with disorientation or confabulation which the patient has, how to deal with how, when the patient mixes memories or forgets the names or calls wife by some other name or something else. When the patient is emotionally disturbed, he can abuse the family members. He can allege against the family members like they are trying to poison him or steal his money. He can have various hallucinations. How to deal with his allegations? I have dementia patients who have called police against their own family members. How to deal with it? How to keep calm in these situations? How to rationalize the fact that the patient with dementia does not is not the same person they have been used to living with all their life. There is no way you can treat your father or your mother as a different person. People you have looked up to all your life, to see them in this state is very difficult in acceptance also. So how to rationalize and accept the changed personality of their parents is a very important thing that we have to counsel caregivers to learn to deal with. Second thing is how to deal with various behavior abnormalities like agitation, aggression, abusiveness, hallucinations, sleep disturbances. What to do in case of wandering behavior where patients can wander out of the house and not come back and they are found somewhere in the park. How to restrain them, how to put attendants along with patients so that they can look after them. As the stage advances, patients will become dependent for self-care needs. How to facilitate self-care needs, then how to socially interact with them, play with them, engage them so that their time is fruitfully utilized, do some intellectually stimulating games with them so that they can preserve their memory, how to involve social workers and other people who can actually give respite to reduce the caregiver burden so that the caregiver can have rest for some time, because when there is single caregiver burnout is a huge issue. Then we have to tell caregivers how to handle the finances, how to deal with financial organization as the dementia in the patient will progress. Then we have to look at sometimes single in nuclear families where both husband and wife go to work. They have to look at safety and security of the patient and of the house also. At some point of time in India now, the concept of institutionalizing a patient, there are care homes for elderly patients where patients can be kept for some time. If the caregiver is not able to take care of the patient, what are the available facilities around their own environment where they can send the patient for a couple of hours to release the burden? Or they can put a daycare center where the patient can be treated for some time while the caregivers are not at home. Or when to institutionalize the patient so that paramedics and dementia care homes can take care of the patient is all needs to be clearly advised and counseled to the patient's attendants at every time based on the state and need of those patients. Thank you.
Thank you very much, sir. So that was very elaborate. You did speak about so many topics which are very important, but most of us may not, understand, or even the family members can understand these things. So thank you very much for that. I think we have covered most of the questions which were related to this particular topic. I think we had a very wonderful, elaborate, fantastic session uh, on the dementias, particularly on the Alzheimer's disease or its the clinical signs and symptoms. We did had a very nice discussion on the examination, the genetics, the reversible dementias, the role of self-esteem. So Dr. Praveen did speak about very nicely about the care groups and how to take care of the family members, the risk group. So that's very nice scientific session we had. I think we can wind up at this. I would like to thank all the speakers, and I shall hand over it to Dr. Ritika.
Yes,
Dr.
thank
Ritika.
you so much. Yes. So I would like to thank all of you, to take your time out of your busy schedule for this session. It was indeed a very insightful session for our viewers as well. So I would like to thank all of you for your time. I know it's very precious, and you guys are very busy, treating the patient. But actually, talking about dementia was something that our viewers are, this is a awareness which our viewers also need to see. So I would like to end this session here, and I would like to thank all of you for being here.
Thank you.
Thank you very much.
Thank
Thank you, everyone. Thanks.